and welcome to this session with Steve Powers and Ruth May. I'm Graham Jackson, I'm a GP. I'm the Senior Clinical Advisor to the NHS Confederation and the Chair of NHS Clinical Commissioners, and I'll be facilitating this conversation today. So a few opening remarks from me, and then we'll get some comments from Steve and Ruth, and then go to a Q&A. When we get to the Q&A, if you want to put your questions into the chat bar, I'm happy to pick them out and ask you to, maybe you can come on camera and ask a question directly to Steve and Ruth, or either or both. So today we're thinking about reflect on the pandemic and ongoing recovery and the issues about clinical leadership within that. So today here, we've got between us, you know, one would say top doc, top nurse, and some bloke from primary care. And that sounds like the leadership team that's in the ICS framework for an ICS body, as I read it from yesterday. So there we are, we're already starting our own ICS team between the three of us. So I think the serious part of that is to say that that framework was published less than 24 hours ago, and I think it has landed pretty well with the people I've talked to, have had a chance to read it through, and been well thought through. So clinical leadership is a conversation for today, but let's be honest about this, clinical leadership cannot work in isolation. I'm a great believer of the leadership triumvirate, and what I mean by that? By that I mean the strength of clinical leadership working in partnership with managerial leadership and with lay, public and patient involvement. You need all three bits of that leadership to make it be effective, whether you're looking at a local or neighbourhood level or an ICS level. That clinical managerial lay combination is critical to make sure we reflect the needs of our population. So the pandemic has really demonstrated the benefits of integrated working, what we're all aiming for. Integration at the interface, integration with local authority, integration with communities, and between disciplines. And that discipline issue is something we need to build on going forward, not only in clinical delivery, but also in the vaccine program that we've had over the last 6 months or so. So our collective challenge is to build on that integration that we've seen over the last 6 months and to make sure we don't slip back into old ways. Now, in the title of this session, we've used the word recovery, and I challenge that a little bit. Recovery implies getting better back to your pre-morbid state. And I'm not sure we want to go back to the pre-morbid state of the NHS. I think we need to certainly recover, but move on and build back in a different way going forward. So just the Confed we're pleased to be commissioned about in the spring this year to do some work about clinical leadership in ICSs. It was led by myself and Lou Patton. We did wide engagement, and we put a paper back to NHS EI, which I'm very pleased to see that some of those feedback from our clinicians around the country are in the ICS framework from yesterday. And there is more to come with the building of the clinical guidance that's set along the framework going forward. So setting the scene there, I'm very pleased today we've got two of our leading clinicians who are great to get this informal chat with them. So going to Steve first. So Steve, you can give your reflections, and then we'll take Ruth.
Well, thank you, Graham, and good morning, everybody. It's a real pleasure to be with you at Confed again, even though we're not in Manchester Central and we're doing this virtually. And of course, particularly delighted to be sharing the session with Ruth May, reflecting on the past 18 months of the pandemic, and as Graham has said, what we need to focus on as we all move forward. So I'm sure you will all agree it's been a really remarkable year, almost certainly for everyone, the most challenging of our professional lives. Personally, I have been overwhelmed by the passion, the focus, the dedication, and frankly, the sheer determination of colleagues throughout the NHS as we have collectively responded to the pandemic, working throughout to ensure that patients with COVID, and of course those without, have been able to receive the care they need during this incredibly challenging period. In the same vein, the public has responded magnificently in our moment of crisis by adhering to guidance and by stepping up to volunteer. We've had over 400,000 volunteers come forward, and I think we've seen exactly what can be achieved when we engage effectively with people right across society and appeal to their better nature. Now, the NHS, I think everybody in this session knows, is sometimes unfairly portrayed as bureaucratic and slow to act. But as Graham has, I think, hinted, my first reflection is that we have really shown just how flexible and adaptable we can be. From ICUs flexing their capacity to triple what their normal capacity is, to staff working in settings in which they don't normally work whilst being apart from family and friends for long periods of time. Our workforce has shown time and time again just how agile and flexible we can be. And of course, most recently, we've seen that in the vaccine program, aided by the huge mobilization of volunteers. Now, the vaccination program mantra has been jabs in arms, not in shelves. And in the 6 months since that historic first jab on the December the 8th in Coventry, 198 days to be exact, the NHS across the UK actually has done an incredible job to deploy our biggest and fastest ever vaccine program. Almost 80% of the adult population had their first jab, and almost 60% have had their second. I'm sure you will all remember those fantastic images of Maggie Keenan getting the first jab broadcast around the world. I personally remember the day very well. I was privileged to be in a cold and very foggy Coventry for that first jab. I was up at 5 o'clock in the morning to do my first round of media interviews. And you know, it really did feel like an historic moment. I recall saying at the time that it felt like the beginning of the end. And I still think that's true, because after all, vaccines are our way out of this pandemic. So my enormous personal thanks to all the staff, volunteers, and everybody who's brought the country, particularly recently with the vaccination program, through what has been a dark time. Now, my second reflection is that emergencies require innovation. We've certainly seen plenty of those over the last 18 months. We've seen the development of many new clinical pathways, remote monitoring, improvements in non-invasive ventilation. I could go on. As Graham has indicated, the pandemic has truly changed the way we all work, and we now need to capture that innovation, particularly the innovation, of course, that's worked better for our patients and for our workforce, and make sure that we simply don't revert back to our old ways of doing things. Thirdly, I believe the pandemic has brought into sharper focus the commitments we all made within the NHS long-term plan. When I reflect on the plan, published of course at the start of 2019, the pandemic has simply emphasised to me the need to concentrate even harder on its key elements, whether that's on prevention in areas such as obesity, on reducing health inequalities, on key disease areas such as cardiovascular disease, stroke and respiratory disease, on the need for digital innovation in healthcare, or on its focus, as you've heard from Graham, on partnership working across local health systems. The pandemic has shone a harsh light on all of these and shown that we need to focus even more on these areas. And finally, yet again, we've seen the immense value of clinical leadership at all levels of our health service. Clinicians have led the surge capacity in critical care and intensive care. Clinical scientists have developed vaccines and treatments, including, of course, dexamethasone in the recovery trial, which has potentially saved over 1 million lives across the world. The NHS at its best, setting up clinical trials at scale and at pace. And of course, it's only yesterday that the latest output from that trials program, the use of Regeneron monoclonal antibodies, has been published and showed a benefit for patients given the treatment in hospital. And here in my team, my own clinical fellows on our National Clinical Fellowship Scheme, our Leaders of the Future, have worked tirelessly throughout to provide clinical advice to our national COVID-19 response program. And of course, again, in my own field, I know that thousands of medical students have had their studies interrupted, but have volunteered as healthcare assistants in patient proning teams, and even providing childcare for NHS staff. So I'm truly grateful for the outstanding clinical leadership demonstrated across the NHS, and I'm really delighted that we're starting to see this translate into enthusiasm from our young people to enter healthcare and join the NHS of the future. Now, if the last 18 months have been challenging, the months ahead will surely bring their fair sense of new challenges. As we've said, we've embarked on the largest mass vaccination program in the NHS history, and that is incredibly successful. But of course, as we do that, we need to constantly keep a watchful eye on the virus as it mutates and adapts. And of course, we need to adjust our course accordingly, and we have done that continuously throughout this pandemic. At the same time, we need to focus on treating patients whose care has been delayed or disrupted because of COVID, all at a time when our workforce is recovering from the relentless nature of the work they've had managing the COVID peaks. It's true we'll certainly all be living with the effects of this virus for some time to come. Now, we have many crucial priorities to address: the elective backlog, an impending new wave of COVID cases. We need to watch carefully over the next few weeks to see how rising infection rates translates into hospital admissions. And of course, long-term effects of COVID, in particular long COVID, potentially affecting over 850,000 people across England. And of course, that's why on Tuesday, Simon Stevens at Confed in his speech announced our plan to tackle long COVID. 89 assessment services are now established, 15 paediatric hubs are being rolled out, £30 million invested in primary care and £100 million for assessments and rehabilitation. And whilst we've been responding to COVID, we've also been ensuring that we remain as focused as possible on improving healthcare and the health of our population. Now for me personally, that has meant continuing work on the cardiovascular, stroke and respiratory ambitions articulated in the NHS long-term plan, the programmes that I have responsibility for here at NHS England. And although it's been challenging, we've been determined not to lose momentum. And in that respect, I'd really like to pay particular tribute to our partners who help lead these programmes, the Stroke Association, the British Heart Foundation and the British Lung Foundation. Now, as an example, during the last year, the NHS has completed a national rollout of specialist stroke networks across England as part of a drive that could prevent as many as 1,000 deaths a year. 20 integrated stroke networks covering England are now responsible for supporting patients through every stage of the stroke pathway, from prevention initiatives aimed at addressing health inequalities to cutting-edge treatments and innovative rehabilitation services, reducing death rates and long-term disability. The networks ensure that patients are supported through every stage of their treatment and offer quicker access to better treatment and rehabilitation, saving lives and preventing disability that can drastically impact a stroke survivor's quality of life. We're also making progress on our ambition to increase out-of-hospital cardiac arrest survival in England from just under 10% to 25%. Bridging the gap between us and countries like Norway, where 73% of bystanders are willing to try CPR when they witness someone collapsing. Now, only last weekend on Sunday, we witnessed Christian Eriksen, the Danish footballer, collapse on the pitch during a Euro 2021 match. It's clear that Christian's life was saved by urgent medical attention on the pitch, just like Fabrice Wamba was 9 years earlier. The quick application of CPR can make the crucial difference between a life cut short and a life lived. So today I'm particularly pleased to announce the launch of a new partnership with St John Ambulance to deliver an NHS programme encouraging everyone to learn CPR and how to use defibrillators. As I've said before, during the pandemic, tens of thousands of people volunteered to support the hugely successful NHS vaccination programme, and many more took up roles delivering medicines or checking on vulnerable people shielding at home. Since Eriksen's collapse at the weekend, we've also seen kind-hearted Brits sharing information online on how to do CPR and how to save a life. So today I'm calling on them to go one step further and undertake formal CPR training, as we know this will mean more lives like Christians will be saved. If more people had the confidence and the skills to call 999 quickly, deliver effective CPR until the ambulance crew arrive, and use a public access defibrillator, the number of lives saved would double. We've seen a massive rush in willing volunteers to help life-saving activity during the pandemic, and we now hope that even more people will be inspired to join our CPR army and become lifesavers. Already, St John have told us that they've seen a 1,000% increase in calls asking for CPR training just since the events of the weekend. So I'm confident that with the public support and through our partnership with St John, we will save many, many more lives. So Graham, in conclusion, our work continues, but with an important difference. We've learned much from the pandemic, and we must now apply those lessons whilst we continue to tackle the big health challenges facing us in the months and years to come. Back to you.
Steve, thank you very much indeed. There's lots and lots we can reflect on there, and actually just that last bit about working in partnership with our patients and our populations for health outcomes. So getting everyone involved is crucial. I'll pick up one thing just to reflect on, just to see for us looking later on. Workforce. You talk about the workforce being flexible and agile, and absolutely. I would add passionate to that as well. But of course, we need to remember the other caveat, which is that workforce needs protecting going forward. That workforce is, they'll only carry on being an agile, passionate, flexible workforce if we look after them into the next phase of delivery. So next, coming to Ruth. Ruth, your reflections, and then we'll go to the floor. And people can put questions into the chat at any time, and I'll bring them back to Steve and Ruth afterwards. Thank you, Ruth.
Thank you very much, Graham, and thank you for allowing me to have a conversation this lunchtime with you. My first thing, of course, is to say a very big personal thank you to everybody that has been providing care, either in a frontline position, in and out of hours over these last 16 months, or in a clinical leadership position. It has been, I would say, and I know that colleagues and particularly Steve has just covered it, it has been the most challenging of my professional career. And yet it's also been the moments that I have never, ever felt so proud to be a nurse, never, ever felt so proud to work in the NHS as well. And of course, the clinical leadership teams that you and colleagues are leading have been at the forefront of this pandemic response. For me, one of my personal reflections has been the value of teamwork, whether that's me witnessing it, me being part of a team on a Sunday morning at a critical care unit at my local hospital, working alongside new people into critical care, as well as those people that are very experienced in critical care, how we all came together from different backgrounds as a team supporting our patients. Whether it's equally true of some of those directors of nursing that were part of my Sunday afternoon club, where it was always a Sunday afternoon that I needed some extra advice and support and listening and challenging ear. And seeing that Sunday afternoon club, seeing that those people that have come together as part of that advice into now as a strategic advisory group, how we've taken lessons learned from this pandemic over this last 16 months into something going into the future. Of course, I've been incredibly proud about the way that people have wanted to come and support the nursing and midwifery profession. I've been immensely proud that the interest in nursing has increased. We've had 34% increase in the number of applications for nursing courses. So our future nursing pipeline is very, very strong. We've seen 13,000 plus new healthcare support workers since January this year. So the interest in our NHS is very, very strong. Steve talked a lot about volunteers and the role that they've played. And I'm hugely grateful for each and every one of them and what they've done to support us in all sorts of roles. But that couldn't have happened without the clinical leadership. It couldn't have happened without clinical leaders at all levels supporting those volunteers. And that is important. Of course, during all of this, babies have still continued to be born. And thank you to all of those midwives, obstetricians, neonatal staff, all of those staff coming together to ensure that those babies have continued to have excellence in care. And indeed, of course, their mothers and families too. So it was with great pleasure, actually, in end of March, that when we took the paper to the board, our public board, about the learning and the lessons from Shrewsbury and Telford and Donna Rockerton's report, that part of our response was how do we invest in the maternity workforce? And seeing that we have been building the work on, our work has been built on the work of the Maternity Transformation Programme, of course led by Sarah J. Marsh and of course Baroness Julia Cumberledge. But seeing the investment now going into that maternity services was a great place to be. So seeing £95.6 million recurrently, which will give us more than 1,000 new midwives and over 80 consultant obstetricians. Delighted to see that. Throughout this pandemic, though, another reflection for me has been the importance of health and well-being of staff. It's been great to see what the people plan is now come into fruition in terms of the health and wellbeing offers, and particularly the hubs in each of the regions. More work is needed on this during the next few weeks and months, as not only our services recover, but also our people recover. So we've seen long COVID plan that came out earlier this week or last week. It's good to see that investment in there, but also the recognition of the role of nurses in supporting and coordinating the long-term holistic clinical care that's needed for people that are experiencing long COVID. I'm delighted too to see within it the critical public health role nurses have in the education of patients and families. More to do, and it's good to see it in there. So when I now consider moving from my reflections to the priorities over the next few weeks, months and years, I continue to have those three main priorities around workforce, continuing to build it fit for the future, importance of infection prevention and control and the excellence and consistent implementation of that, and of course, our maternity services. So retention is going to be important, isn't it? How do we keep those people that we've got in our services right now? And that I'm sure that much work that you are already doing, and thank you for the work and the leadership that you're doing to keep our staff. But also to continue our international recruitment programme, even in this global health emergency, even in these limited travel environments, we have continued to see increasing numbers. Over 10,000 people have continued to come from international waters to be part of our NHS. One of the things that we'll continue to do as well with regard to workforce is concentrate on our undergraduate supply, making sure that we support those students, nurses and midwives and into our long-term work. We will continue our healthcare support worker programme as well. And of course, building the next generation of nurses, working with our schools, of course. But really important to me is how we support those nurses and midwives from an ethnic minority background. I'm delighted and I'm really grateful to colleagues at the Mary Seacole Trust and indeed the Florence Nightingale Foundation about how we've really harnessed and worked in partnership with those two foundations to support a number of leadership programmes supporting our ethnic diverse nurses and midwives. I'm delighted to have seen over 60% of those core students have received promotions. Wonderful to see it actually making a difference. As well as that then, as I'd like to continue to prioritise developing the leaders of the future and how we ensure that we build a successional pipeline of future leaders. My third priority and my final priority is as big as my first priority, and that is around maternity services. It is vitally important that we continue to build really strong, safe maternity services. So whilst we've seen the £95.6 million money going into this, now we've got to work hard to recruit those midwives and to recruit those obstetricians so that we can utilise that properly. But today also I'm pleased to see that NHS England and NHSX collectively working together, we will be giving £52 million of investment into digital maternity records. It's important for us to remember that right now in many units, women are there with bulky paper records. And as a result of this money and the work that will go on to ensure that we will get rid of those, so bulky paper records should soon be banished. And that is what we want to achieve by this joint investment through NHSX and NHS England. And it will fast track this work so that digital maternity records will be accessible to all women across England. So final comment then, Graham, would be a very big thank you. thank you from me to you for the enormous amount of work and leadership you have given to my professions over the last 16 months. But I recognise too, the ask is going to be there again, because we'll want to, as Barbara put in the chat box, we don't just want to recover, we want to recover, adapt and innovate. So thank you, Barbara, for that very final comment. Thank you, Graham.
Thank you, Ruth. I have some questions coming in. I'm going to come to Kat in a second, and you put your camera on a second, Kat, I'll bring you in. But I mean, just reflections, a couple of reflections about, I mean, the digitalisation is fantastic. I mean, we need the digital infrastructure, don't we, going through. I mean, as a GP, I haven't physically written with a pen in patients' records since 1995. And isn't it a shame that we're now this far down the line that it's taken us to get the whole system going. But we're getting there, it's fantastic. And we know that digital agenda is so important for joined up healthcare across the different parts of the system. So I'm really pleased to hear that maternity issue. And the other thing to reflect on is you both talked about clinicians a lot, which is great. And I think the language has changed over the last couple of years, away from the doctor-centric environment. And then it was just doctors and nurses, and it was doctors and nurses and pharmacists. I think, now we talk about clinicians, we recognise that at all levels in the system, the input that a multi-professional team can give is better than the sum of its parts. Are so important. On that, I've got a first question from Kat Dolby-Welsh about nurse leadership in primary care. So, Kat, do you want to pose your question for me? And off-mute yourself.
I was just practicing my jaw movement.
Okay, good, thank you.
Really good to see you. I think one of my questions.
Sorry, Kat, can you just introduce who you are? Apologies.
Oh, sorry, yes. So I'm Kat Dolby-Welsh. I'm a nurse clinical director of Yeovil in Somerset and the PCN board member for the Southwest. My passion, of course, is nurse leadership, and it's been a really interesting journey of the last 2 years, developing within during COVID and within the ICS. And one of the things I noticed is how will we ensure a strong nurse leadership? Oh, crikey, postman's died.
Is that your dog?
Yeah, like
carry on.
Strong nurse leadership and help GPNs to not lose their voice in the ICS. We weren't picked up as an Rs role. We don't have that. I fear we're losing it. And nurse CDs, there's 15 out of 1,290. And yes, there are other roles. So this would go for paramedics and pharmacists and physios. And we've got the fantastic shiny minds. But what's your thoughts on how we build on that? How do we make that being a nurse clinical director, it becomes normal, is not an exception?
Thank you, Kat. I love the fact that your dog has also joined the conversation as well. It just makes me feel more human now when my daughter comes in or whatever. Thankfully, she's at school. So, Kat, wonderful question. And of course, it's good to see that you are leading the way, as well as some of your colleagues in leadership in PCNs. There's much more work we need to do. And why is there only 15 PCN nurse leaders? I am really pleased that we are supporting the development of nurse leaders from wherever they are, but there is more work to do. And I was only talking to Crystal Oldham yesterday or the day before about the Q&I Exceptional Nurse Leadership Programme and how we're going to really develop that and support that, and agreed to work with her and continue that funding. So, Kat, yes, we've done some work, more to do, and Kat, I would love you to help me to really put some speed around that, if that would be okay.
Be fab. Thank you very much.
Challenge back to you, Kat. There we are. So you can't take your dog to Manchester Central, can you? But you can bring it into the meeting here. I just got to pick up on the elective recovery, which Steve, you mentioned, and I think that a lot of us are concerned about elective recovery being focused on secondary care management of waiting lists, which I guess ostensibly what it is, but actually what we have learned from the pandemic, what we've learned from integrated working and multi-professional working, is that actually patient pathways that we would initiate today are different than we may have initiated 18 months ago. So how do we ensure that we do that elective recovery in a way that is 2021 and not 2019, and think about how we engage so many different parts of the system going forward. Have you either of you have any thoughts on that? Because it covers everywhere.
Yeah, thanks, Graham, and of course dogs and remote working. So I did an interview for Good Morning Britain first thing this morning, and I'd gone upstairs to do it, and my wife was trying to keep our young Labrador silent below, and just as the interview was about to start, I dropped my iPad on the floor, which of course resonated down into the room below, and this barking started. Oh, goodness me, a good start to the day. But anyhow, so my sympathies, Kat. Yes, so I think you're right, Graham, on elective recovery. It's obviously a large focus on people waiting for procedures, surgery, but it's so much more than that. So diagnostics, for instance, is a key component, and so the work that we are doing on the back of Mike Rich's review on community diagnostic hubs will be a really important transformative approach to the way we manage the diagnostics pathway, or part of many pathways that lead to procedures or to diagnosis. So that's back to your point you made right at the start, which is not going back to the way we would have done it prior pandemic. We need to go back to a different way of doing it. The GIRF team are taking a lead role with many other people around NHS England, NHS Improvement, some of the regions on re-looking at some of our pathways of care. I know a lot of that work goes on integrated care systems at local level, but this is the opportunity to rethink pathways of care, whether it's a cardiovascular pathway or it's a musculoskeletal pathway. And of course, a lot of this is not entirely new. It's work that we began before the pandemic. It's work that's evolved over years. And hence back to the comments I made in my reflections that for many things, the pandemic has simply heightened the urgency at which we need to be doing things that we had already planned, as much as throwing up completely new things. But I think you're absolutely right. The opportunities of digital innovation, the diagnostic technologies that we're seeing should all be leading us in a direction of doing this differently. And my final reflection is of course, for patients on waiting lists, what they need most is to know what's happening. They need to be communicated with. They need clinicians to reassure them. And sometimes they need reviews. Sometimes they need not to be left, because things will have evolved. So I know all of that has been happening during the pandemic, and of course it needs to continue happening, because obviously we all know at the end of those statistics there are individual people waiting for care or for procedures.
And I'll come to Ruth on this. I mean, I think absolutely it's a very wide situation, and there's the social prescribing elements and the way we do think about referrals and shared decision making. Yeah. But Ruth, there's also an issue about community nursing in the elective recovery situation. And any area I talk to, you mentioned Crystal there. I mean, she would, if she were on the call, which maybe I don't know, she would say this as well, that there's been a big hole punched in the community nursing provision. And we it's struggled to provide that. And what an important part of the workforce to support pre-admission, post-admission, ongoing care, chronic disease, primary care. So, any comments about the community nursing side of this, the elective recovery?
Yeah, absolutely. So we've seen the number of district nurses going down over the last several years, to great disappointment. One of the things that we've done, though, is to increase the number of district nursing training programs, and that is really important. Mark Radford from HEE has put in a significant amount of money and to increase that by at least 50%. But we need more district nurses, and we need district nurses with a specific SBQ qualification so that we can encourage future holistic approach to district nursing. And of course, it's going to need that for how we're going to care for people with long COVID, because most of these people are going to be in the community. They're not going to be in an acute setting or in a specialist clinic all the time. They're going to be in the community living their lives. So district nursing is a real importance area for me, and Crystal and the Q and I are great partners promoting that.
I think it's critical, isn't it? Absolutely critical. There's a question from Alex Stewart. Alex, do you want to put your camera on and come and ask your question about learning disabilities?
Hi, yes. So I'm Alex Stewart. I work for the NHS Confederation and I support our Mental Health Medical Directors Forum. And yeah, I think just I mentioned as it's Learning Disabilities Week, it's really interesting to hear about the kind of ambitions for building clinical leadership to kind of better support that cohort of people who can face significant health inequalities.
Ruth, learning disabilities first.
Yeah, absolutely. So I am really proud of the All England Learn Disability Plan that colleagues, Helen Lafferty and colleagues have helped us to build with, of course, the fabulous David and Ben. Brilliant. But what we started off a couple of years ago is say, look, we haven't got enough supply of learning disability nurses. And I think district nursing would have been there where learning disability nursing is if we hadn't have taken the action with district nursing. But with learning disabilities, we recognised we needed to attract more people into being student learning disability nurses. And that is why we put an extra £1,000 onto the maintenance grant. So if you're a student nurse or midwife, you get £5,000 a year. If you're a student learning disability nurse, you get £6,000 a year, and that has made a massive difference to the number of people encouraging to come through. But actually, right now, we want to make sure that we promote learning disability as a fabulous, privileged part of the nursing profession, and that is what colleagues have been doing as part of the All England Learning Disability Plan. More work to do though, because learning disability nurses are still not increasing in the numbers we like.
Thank you, thank you. Long COVID, Steve, Ruth, you both mentioned this. Come to you, Steve, first on this. I mean, the long COVID clearly is going to be impacting our lives going forward, our delivery, our reflections, our acute care, our commissioning decisions. And at a time when, I mean, arguably, as you know, I'm an ex-CCG leader myself and still represent commissioners nationally. You know, at the time when during change this year, commissioning leaders may struggle to commission new services. There was a great paper published by NHS England in June or July last year about all the multiple system diseases that come from long COVID. And I know there's a lot of work going on. I sit on the task force chaired by Kieran Connison, and that was relaunched last week, and it was a really, really useful group of people. But I think, you know, we talk about long COVID as, you know, an issue is coming down the line, but whenever you think about it, it's so multi-system. It covers all multitude of providers, voluntary sector, volunteers, and acute sector. How do we maintain broad clinical leadership about delivery of long COVID services? Because it's going to be quite challenging. Steve?
Yeah, it is a big challenge, and I gave some numbers in my reflections. And of course, one of the challenges is working out exactly how many people and over what period of time we will need to care for. And that will, you know, our understanding of long COVID is at a very early stage, clinically and scientifically. That will evolve as we study this more, as more data comes in. And of course, one of the things I'm really hoping that the clinics we set up, the structure we set up, will teach us more about the nature of this disease, this disorder, and then feed back into how the service evolves. But it's at a very early stage, and it could be one syndrome, it could be several syndrome, and that was one of the reasons we commissioned NICE very early on to do some work to come up with some clinical definitions to help clinicians. I think the second point I'd make is that we have tried to design in some local flexibility around individual systems working to strengths and serving their particular populations and population needs. I think some of the early COVID, long COVID clinics came out of respiratory medicine, which of course will have been at the forefront of the COVID response. It's fundamentally initially respiratory disease, but you're quite right. It's long COVID can affect, you know, the heart, the autonomic system. Obviously there are psychological and brain elements, and there's a whole spectrum of things. So I think one of the key challenges for systems is to get that right balance of expertise. And you know, I kicked off the work on long COVID in NHS England, and my team still provides support into Ian Dodge and the team, and Kieran, who are doing taking the lead at the moment. And I spent time early on listening to patients with long COVID, and of course one of their big concerns was around fragmentation of treatment, being sent here for the heart problem, here for the respiratory problem. And again, not unusual. We hear that with people with multi-system problems, but it's really critical if you're somebody with long COVID. You want to be listened to. You want to make sure that primary care physician knows where to signpost you to, and you want to be sure there's a holistic response of multi-professionals and multi-specialties waiting to help you. So I think a really good start, because we've had to get this started, very rapidly, but undoubtedly a lot more work to be done, and a lot more to learn. And I'm really grateful for all the local clinicians who've been driving this forward, and actually, the patients and the patient groups are helping us. This is a combined effort to stand up something at very quick notice in response to what is clearly going to be a considerable challenge going forward.
Yeah, it's a big challenge. Just come on, Bruce, you've got a comment.
Yeah,
yes, please.
Just a quick question, comment, which is, much of this, of course, will need to continuation of research, because we're all going to be learning about long COVID, and we're all going to be needing to take the very latest of the findings that we can. So I really appreciate the nursing the people in nursing that are actually researching this as well. So Elaine Maxwell, for example, has been doing a fabulous pieces of work, contributing to the very big research evidence that no doubt will come. So I think research and research colleagues, this is a big area for them to contribute to.
Brilliant. In fact, you just led nicely into my final question, really. But I mean, just a reflection on the long COVID, my perspective is that we are seeing we need to support the system to see we're investing ostensibly in a tertiary environment, because that's the way we have to invest at the moment. There's paediatric hubs that were mentioned by Simon on Tuesday, but it's because it's presenting in the community and it's presenting in primary care, and people don't come out of hospital with a nice little badge saying "Watch out for long COVID." C19 PCR was positive, and as a primary care physician, I can tell you it is really challenging to work out where these cases are. And being cognizant of it, it's quite a challenge and I'm sure this is going to be building over the next few months as people get used to the presentation phase. It's so multi-systemed, it is really difficult before we get to the diagnostic phase. So,
yeah, and that's why, Graham, of course, we've been working with the College of GPs, for instance, and other partners to really help primary care to spot this and to know what to do with it. And of course, many people who are affected haven't been to hospital. And indeed, going back to the autumn, of course, because in the first wave, test capacity was limited, many people hadn't had a test positive diagnosis of COVID, which was even more challenging. Obviously, that will have changed over the subsequent waves, but it is an emerging challenge that we have to be agile, fleet of foot, and agile, flexible in our response. And the final point back to the research is we need to do both the research in those who've been hospitalized with COVID and then develop long COVID, but also those who have not been to hospital and follow through in those who have, actually acquired fairly mild disease and then developed long COVID.
Yeah, we're just getting to the last minute now, and I was going to just touch on finally was an innovation. You mentioned it, Steve, in your opening remarks, and you sort of placed the research as well. And I guess it's a plea. You can have a comment on it, but it's really important that we still support innovation, the work that's been done through research, done through the academic health science networks, plug that into the change in behaviour. But actually, when we move forward and we concentrate on recovery, just to recovery, it's sometimes easy to think it's too difficult to do new stuff. So I guess really it's just making sure we've got good top level support for that clinically led innovation, because to me it's a no-brainer.
Yes, and innovation, of course, covers the whole spectrum of things, and we could talk about any one of them, from innovation in clinical pathways to innovation in treatments to innovation in device engineering, etc. One thing I have been reflecting on very recently with the chief medical officer is I mentioned it, the recovery trial. everybody in NHS is passionate about research and doing the work that will improve the health of future generations and current generations. But sometimes research is hard to do. Sometimes it is just hard. But we have all been struck by the recovery trial. Some of the biggest recruiters were not teaching hospitals, district general hospitals, our traditional DGHs. The speed at which people recruited, the enthusiasm which both patients and staff entered people into clinical trials, and wouldn't it be great if we just captured that in sort of normal times, not pandemic times, because actually the results of those trials are so powerful and don't just benefit patients here in the UK, they benefit patients throughout the world, because they tell us on a rigorous scientific basis what works and what doesn't. We highlighted, I've highlighted the vaccine program as the way out, but therapeutics is an important way out of the pandemic as well. And we shouldn't forget that over the course of the last year, we have already identified treatments that are improving outcomes in COVID. So this is as critical as, all the great vaccine work we've done.
Brilliant. Any final comment from you, Ruth?
Yeah, just one point, which is the NHS and clinical staff across the NHS have been innovating for years. What's different for me and my reflection is that we've done it at huge pace, and that's what I'd quite like to do it in the future. Is let's do it at the pace that we've done it during this pandemic into the future, because then we can really make some speedy changes to the care that we're giving.
Brilliant. Thank you both for having this conversation with me today. I think it's been very, very interesting and very useful, and we could have gone on for a lot longer. So thank you all everyone listening in. Secretary of State is up at 1:30 with Victor on stage, followed by Chris Whitty. So the afternoon is not yet over. So we've got lots more coming up at Confed. Ruth, Steve, thank you very much for your time.